Good morning or afternoon, everyone, depending on where you're joining from. Thank you very much for joining this session, which we're really excited about. My name is Sumit Gupta. I'm a pediatric oncologist at the Hospital for Sick Children in Toronto. And on behalf of the other organizers, Laura Carson, Dr. Simon Sutcliffe, and Dr. Anna Dare, it's a pleasure to welcome you to this workshop about the intersection of universal health coverage and global cancer control. We have three extremely eminent speakers that we are lucky enough to have agreed to join us today. I'll introduce, without any further ado, the first one. Each one will have 10 minutes to talk about their experiences with this topic, and then we will have a 30-minute discussion about the topic at the end, which I'm very much looking forward to. So our first speaker is Dr. Beverley Essue. Dr. Essue is an associate professor of global health with IHPME in the Dalla Lana School of Public Health here at the University of Toronto. She has affiliations with both the University of Miami and with the George Institute for Global Health in India. She is an extraordinarily experienced global health systems researcher and health economist who's done great work with some of the major publications and bodies that I think we've all heard of, whether that's the Disease Control Priorities Group or the Lancet Task Force on Non-Communicable Diseases. So without any further ado, so as not to cut into her time, I'll let Dr. Essue take over here, please.
Thank you very much. Can you hear me okay?
Yes, perfectly.
Perfect. Okay. So it's my absolute pleasure to join you all today, and a real honor to have been invited at this workshop and to be among such an esteemed lineup of global experts, especially on this panel in particular. So I really want to thank the organizers for the invitation and the opportunity. I want to start by acknowledging that today I'm joining you from the southwest part of Toronto, which is the traditional territory of the Haudenosaunee Confederacy, the Wendat, and the Mississaugas of the Credit First Nation. And I gratefully acknowledge these Indigenous nations for their guardianship of this land. I thank you, Sumit, for also providing that background context, which gives some context to the perspectives that I will bring to this discussion. So I come at this work as a global health systems researcher who has spent quite a bit of my career looking at non-communicable diseases, as well as at cancer in particular. And I think it's relevant for this audience as well that I have spent some time out of academia at the Canadian Partnership Against Cancer as their senior health economist. And so it's a delight to see some of my colleagues and friends in the audience today. I think Laura is going to navigate my slides for me.
Yes, I am. Give me one moment.
Thank you. So the talk, the question that I will address in my talk today, we can go to the next slide, please, is how will universal health coverage strengthen cancer care globally? We have maybe a bit of a delay. Can we advance the slide, Laura? And then on to the next one. Thank you. Okay, so universal health coverage, it provides a means through which improvements in population health and health outcomes can be realized. It's critical for the development and strengthening of health systems because when and if it functions well, universal health coverage provides the essential care for whole populations, ensuring access to quality health services, while ensuring that those healthcare services are not a driver of impoverishment. It has become and remains a global health priority because it has been strongly linked to economic development, although importantly, health is not the only determinant of economic development, but also linked to concepts of health as a human right and a public good, and importantly, a recognition that as a global community, we have a vested interest in ensuring the health of all populations, made even more evident through the COVID-19 pandemic. The case for universal health coverage has never been stronger. Next slide, please. Many of you will be familiar with the classic UHC cube, which depicts the core objectives of universal health coverage. So along the bottom side is about the population and the breadth of coverage. And ultimately here, we're aiming to increase the proportion of the population covered by a national prepaid health insurance scheme. This is this concept of risk pooling. We want as many sort of healthy and unhealthy, well, as many healthy people into a risk pool to sort of share the risk around. And that's the concept behind a national program. We want to increase the depth of coverage because this entails an increase in the services that are included in a health benefit package. And it's often referred to how deep the package is, starting often from a limited suite of services, defined as an essential package for cancer. Some of you will be familiar with the work of DCP3, and how to expand that out progressively to something that is more comprehensive. The height of coverage is an area that I've spent most of my research looking at, and it refers to this concept of financial risk protection. Essentially, we want to do away with user fees, which have been shown to be barriers to access and drivers of impoverishment in populations. And these are interrelated concepts because ideally, health financing mechanisms are required to ensure that a sufficient public pool of resources is generated in order to be able to provide a comprehensive suite of quality healthcare services that are affordable. Next slide. Can you just click to the animation? So the goal is that universal health coverage will ensure that health systems develop in a way that is not harmful to other social sectors. And it's this connection to health and non-health outcomes that have aligned and positioned universal health coverage within the SDG agenda. If you can click through, Laura, please. SDG, maybe we've missed it, that's okay. So SDG 1, which relates to no poverty, SDG 3, which focuses on better health and well-being, and SDG 10, I would argue, which is focused on reduced inequalities. Okay, so the realization of the goals of universal health coverage and the development of it really rests on the development of health systems. We're getting out of order a little bit. Bear with us. If you can just click to the next slide, please. Thank you. So the realization of the goals of universal health coverage really rests on the development and strengthening of health systems as the platform through which to intervene, promote health and well-being, and to prevent, detect, treat, and manage ill health. Julio Frank and Chris Murray have characterized a seminal framework for understanding and assessing health systems, which is depicted here. So every health system, they argue, requires these 4 core components. The first is around financing, and that entails the way in which you pay for health services. And that can be a mix of public and private mechanisms in place. The second core piece is around the provision. These are the resources, including the human resources that are required to deliver interventions. This all rests on an approach and a strategy to resource generation, which is about how you leverage the resources to fuel the system. And finally, and quite importantly, but often underappreciated, is the stewardship that relates to the accountability and that has to be inbuilt within a system, the setting, implementing, and monitoring of the rules of engagement. Next click, please. And these are interrelated. These core functions are required to enable health systems to deliver on the 3 key goals of a health system. The first is to improve health at the population level, as well as within populations. So here we're interested not only of increasing and improving the health of the entire population, but also looking within populations, thinking back to how you actually operationalize health equity, to understand the way in which those improvements are distributed throughout the population. They are important for fostering systems that are responsive and developing a responsiveness of a system at a population level, as well as responsive to the needs of individual population groups. And third, the third goal of health systems is to ensure fair financing. And this is anchored in the concept of financial risk protection. The concern is really to ensure that the burden of financing is fairly distributed within a population. Next slide, please. You can just do another click as well. Now, the relevance to cancer care is that there is a synergistic and bidirectional relationship between universal health coverage and cancer control that is implicit but has not been fully harnessed and leveraged. Progress on universal health coverage is a key determinant of improved cancer outcomes globally. Likewise, cancer control is integral to the path of universal health coverage. Next slide. This concept of cancer and health systems is being taken up in a Lancet commission that was launched this year that is co-led by Felicia Knoll and Mary Gospodarowicz and Patricia Garcia, on which I have the honor to serve as one of 30 plus commissioners. We have set as an ambitious objective of this work to help to raise the bar on cancer control for everyone, everywhere, and to shake health systems out of an equilibrium of apathy through which some have access to ever-improving treatment and prevention, while the poor while many, mostly the poor, do not even have access to basic care, including pain relief and palliative care. Now, I won't go into detail in the panel that you see on your right, because it's published in the announcement, and I encourage you to review it, because here we've outlined, as the rationale for the commission, what we see are the key synergies between cancer and health systems that define their shared path and that present opportunities for what Mary and David Jaffrey have characterized as why cancer could and should indeed be seen as an exercise machine for health systems. Click, please. So in adopting this diagonal approach to leverage what we know about cancer and what we know about health systems, we get the health system arrangements and requirements right for cancer, the impacts will radiate throughout the system and to other disease areas. Getting cancer right is the path to improving health systems for all. Next slide, please. So what are some of the opportunities, or said another way, some of the obvious places to start and to enhance? What I've described on the next slide is not an exhaustive list, but I've positioned it and framed it within the context of the UHC cube. You can just click through to release all the animation. There's just 3 clicks, I think. It goes without saying that scaling up coverage to ensure full populations are covered by national, publicly funded insurance schemes is of utmost importance, and that there needs to be a transition away from voluntary insurance and employment-based schemes, which leave the vast majority of individuals in low-income countries who work in informal sectors, many of whom are women, out. And they are precarious, as COVID-19 has showed us. So access to healthcare should not and cannot be contingent on employment. Laura, can I have you click through for me, please? We might be having a bit of a delay. We have to go back to the previous slide, please. It's okay. I can speak through it. Are you able to go back? Perfect.
Yeah,
you can just leave it. Thank you. Thank you. On the financing side, cancer has attracted very little funding from development assistance partners. And so mobilizing the resources required means drawing in new donors and funding streams. This requires a reframing of the value proposition, one that better accounts for the myriad ways that cancer impacts individuals and societies beyond the health system impacts. And with this, making a stronger case for the value of information-enabled systems, which have not been well accounted for to date. In 2017, we estimated that there were some 14.3 million instances of cancer-related catastrophic health expenditure in low and middle-income countries. But there are still no systematic approaches to tracking and monitoring the ongoing reliance on out-of-pocket costs within systems and the impact that this has on individuals and treatment outcomes, besides a selection of smaller ad hoc studies. And this is key to advancing on the goal of financial risk protection. Finally, progressive universalism provides the framework to guide countries in scaling from a minimum set of interventions that have been defined in an essential benefit package for cancer to a more comprehensive suite of interventions that better align to the needs of the population. This must be guided by priority setting that it can account for the value of integration of specialist cancer services into primary and community care, as well as the strong potential for new advancements in diagnostics and treatment to allow for innovation-enabled leapfrogging within systems. Priority setting that moves from assessing individual interventions in isolation to assessing what they represent within a continuum of care has to become the standard. There is also a terrible bias, which was alluded to in the previous session, which was mentioned in the previous session, in the current models of cancer research investment. And the literature reflects a narrowly defined research agenda that is not accounted for or taken up the breadth of research, especially health systems research, required to address the global cancer burden and action towards closing the cancer divide. I encourage you to read the editorial in this week's Lancet Oncology, which makes a stronger case for more inclusive models of cancer research investment. Last slide, please. Finally, we can't have really any talk without mentioning COVID. And so while it is true that COVID has been a major disruptor to health systems and to cancer care systems around the world, if you could advance to the next slide, please, Laura. There are a few silver linings that present opportunities if harnessed within the COVID recovery planning. If you just go back one slide, please. I've outlined a few key areas on the slide, which will come in a minute. And in the interest of time, I'm not going to take you through them, but I was hoping that you'd be able to read them. Perfect. Thank you very much. So these are some of the silver linings that I think we have to reflect on as we're coming through COVID and thinking about how to, what opportunities there are to build forward stronger, build back better, whichever terminology we want to use. Health is on the agenda in a way that it never has been before. We've seen a redeployment of a workforce and health workforce in new ways, which entails task shifting and a sort of all hands on deck approach to addressing the pandemic that we have to think through how to sustain that and put it to bear within the cancer system, rapid resource mobilization to respond to the pandemic, as well as an accelerated integration of technology into health systems. And I think, importantly, public expectations of and engagement with science with health and within health systems means the expectations are rising, which is one of the drivers that are important for change. So our health systems are currently COVID defined, but will not remain this way forever. The synergies between cancer and health systems present an opportunity to stretch and push the systems in ways that were not previously possible, and if harnessed, will allow countries to advance more quickly towards the goals of universal health coverage. Thank you.
Thank you very much, Dr. Essue. That was a wonderful overview of UHC. I think really sets the stage for the discussion that we're hoping to have today, despite challenges of timing of video conferencing.
It all worked out.
It did indeed, and very well. So our next speaker, I am very pleased to have the opportunity to introduce Dr. Andre Ilbawi, who is a medical doctor and a surgical oncologist who joined the WHO in 2015, I believe, and now serves as the focal point for the cancer program in Geneva, Switzerland. He has been intimately involved with many of the land-breaking reports that the WHO has put out in cancer over the last little while, and has led or co-led or been instrumental in many of the initiatives, including that on breast cancer, cervical cancer, and clearly the most important of all, the global initiative on childhood cancer. So without any further ado, Dr. Ilbawi, it's wonderful to see you. I'll let you have the stage.
Sumit, my goodness, I thought we were going to stay informal. To have such an introduction from a dear friend, a dear colleague, thank you for that. Thank you to our friends from Queen's for the invitation to participate, to Scott, to Laura, and to the team. I know this is, in fact, a very communal meeting, an opportunity for us to reconnect as friends. And though we may not have the opportunity to speak directly today, it's wonderful to be online with so many of you who I have been in touch with in the past and who I still consider inspirations and dear friends. So as Sumit has mentioned, I think this is really a nice opportunity for us to build on that wonderfully insightful and important presentation that Beverley has given, and to understand what are some of the ways that we're working with governments to frame universal health coverage in the cancer agenda. This is how we'll organize the next 10 minutes. First, understand, why does UHC matter? We now understand what it is, but what concrete evidence do we have that supports the importance of framing UHC and the cancer agenda? Well, there are two very simple ones. Number one, we have strong evidence that UHC improves outcomes and promotes equity while ensuring financial protection, as we heard from Beverley. The second, as we also have heard, is the protection against health system threats, and we'll provide an example of that. The simple answer here is failure is not an option. If we are not part of UHC in the cancer agenda, we will be left behind. If UHC forgets us, then we will never really be able to achieve true UHC. So then the next question is, how are we going to achieve this? How do we drive UHC, and how do we impact the overall agenda? First, to advocate; second, to be practical; and third, to invest in people. So let's go ahead and get started. Perhaps as a way of framing it, we talk about that pool of funds, but let's just ask some practical questions. What does that pool of funds look like for a country like Canada? How much money does Canada spend per capita, that is per population, the overall population, an individual in that population, on cancer? And likewise, what would we need to ask middle-income countries or low-income countries to pay in order to achieve a universal health coverage package appropriate for their settings? If we start here, 100 to 500, just as a reference. This is fairly consistent, although of course there are some outliers, including the United States, that does pay more or does expend more on cancer through the overall general government expenditure, through private insurance, and through out-of-pocket expenditure. When we look at for low and middle income countries, I'll pause just to see what we think the answer should be, perhaps greater than $200 or $50 to $100 per capita. In fact, it's not. We can achieve universal health coverage and not have to do so with breaking the bank. So in fact, the suggestion that cancer is not part of the UHC agenda misses the reality. It is in fact part of it, but it requires generating the political will and investing wisely. Where are we now? Who is purchasing services? Where is the money going? So again, if we deal with the reality that most governments right now in low and middle income countries are spending 10 cents, $1, $2 per capita on cancer, compared to $100 to $400, that already is a difficult starting point because we know that absolute dollars do matter. So then let's see where we are in terms of willingness to pay. If governments are able to purchase services or invest in services, are they doing so? And what services are they in fact prioritizing? We're gathering data right now at WHO that is analyzing every country's benefit package and understanding which cancer services, and here in the slide, I've given a small sample of some of the data inputs that we're reviewing. Are they paying for screening services? If so, which type? Are they paying for medicines? If so, which type? What we see here is that there's also a deficit in willingness to pay, meaning cancer is just not a political priority in many low and middle income countries. And what's the consequence? This is the dire outcome. We know that people are paying out of pocket. If the government won't pay, if the money isn't available, a loved one is dying of cancer, something will happen. Someone will sell an asset, someone will sell a home, someone will forego opportunities to ensure that their loved one receives care. This is a moral travesty that this happens, a family in fear selling assets in order to pay for treatment that otherwise can be publicly available. So what is it that we're advocating for? What is the value proposition of UHC and how do we ensure it's inclusive of cancer? Well, let's start again. What evidence do we have? Just recently, as part of our work in the Global Breast Cancer Initiative, we released a study in which we looked at countries, all countries globally, and we identified 3 general patterns of breast cancer mortality trends. Number 1, high-income countries that have seen a decrease of 2 or 3% per year. Number 2, often middle-income countries, not all, but some, that have started seeing some early decreases. And 3, some middle-income countries and most low-income countries that are seeing an increase. We asked what makes the difference? If we could look at all predictive factors and understand why is it that pattern 1 is more consistent in certain types of countries, what are those characteristics of those countries? Is it their UHC score? Is it the presence of a screening program? Is it the presence of a cancer plan, cancer centers, or overall health expenditure? When we look at it through a multivariate lens, we found there's only 2 primary predictive factors. Number 1, does the country offer universal health coverage, and what is their service index score, independent of other services? Number 2, what are the number of public cancer centers that they have? Does current health expenditure correlate? No, in fact, it doesn't. So UHC does not have to be about the absolute amount. It has to be more about the prioritization of services and the capacity to deliver those services. If we start asking this in a more granular level, let's see if we can unpack it further. What does this mean? How do we in fact achieve those overall improvements in population outcomes? Let's start with 2 countries as an example, Uganda, South Korea. What explains the breast cancer outcome of 20% in Uganda compared to 80% in South Korea? Well, there are 5 primary factors that could be considered. Well, what if we start by saying, let's downstage all of the disease in breast cancer so that stage distribution mimics that in South Korea? What would that do? That can make a major improvement, about 20% absolute survival gain. What if we increase the complexity of services, treatment, and diagnosis? Here, in other words, we're talking about new investments in medicines like trastuzumab. Is that going to make a big difference? It's not. That is not going to be a primary driver. It's not inconsequential, but it's not a primary driver. Quality, we can't ignore that there are quality differences, but it is in fact the big investments in universal health coverage and service availability that will bridge that gap. Achieving universal health outcomes will drive that progress in population outcomes, and this is in fact the primary investments that we should be focusing on. And third, as we heard so well from Beverley, we know that the reality is that governments that have strong health systems, governments that invest in universal health coverage, are also those that are able to withstand health strains, whether that comes from economic downturns or it comes from a pandemic. For the purposes of time, I won't go too far into this slide. It's a brilliant publication that came from the Harvard group in 2016, published in The Lancet, looking at trends in mortality during economic downturn, comparing non-UHC and UHC countries. UHC countries that were able to save lives because their health systems were resilient, and the poorest didn't suffer financial hardship or exposure. So how are we going to do it? What do we need to do as a community to drive UHC as the primary entry point for our work? First, start with advocacy. Yes, cancer is known for many of us, but is it heard in halls of governments around the world? And we're so privileged to have Paulyn here because she can help us understand what are those dialogues happening in governments outside of those in the Americas or in Europe. How do we situate cancer when in fact there are other disease programs that are also seen as priorities? Well, to start with the right narratives. Cancer is a personal disease. It impacts every family everywhere. A good way of understanding this is to sit with a politician in a low and middle income country and say, imagine 5 people you love, 5 people you know. One of them will develop cancer in their lifetime. This is in fact a disease that impacts everyone, but we have to deal with that reality by ensuring that it is in the front and center of the dialogue with the key stakeholders. And also to understand that, yes, if we can in fact prioritize cancer, we will see improvements. This has been true in breast cancer, and it's true in the cancer agenda. If we can in fact address non-communicable diseases in the SDG era, we will bend that curve back to reducing mortality and reducing premature mortality from cancer, which in fact will be the #1 cause of premature deaths in the majority of countries in the upcoming decades. Another point, what are we asking for and when? So with universal health coverage, it is a concept that is thousands of years old. Beverley is right, it has come to the fore just since the SDGs now about 6 years ago. The concept is thousands of years old. But besides going through this timeline, a good question to ask is, well, how long is this journey going to take? When will we get there? If we look at countries that have achieved universal health coverage and ask how long did it take to get there, it's not easy. We have to acknowledge that universal health coverage is a journey. Many governments may not get there in our lifetime, but we have to remember that this journey is worthwhile and that we should congratulate each other on each step forward because it is not easy to achieve universal health coverage. The second consideration in our work to promote UHC and cancer is to be very consistent and coherent in our messaging. It is a practical approach. We can see, for example, we advocate for more funds. Beverley is right that overall development assistance for cancer is low, but we are starting to see a huge influx of capital into the cancer agenda. So money is being made available through governments, through development partners, through the private sector, through development banks. So the money appears. Are we ready to answer the question of what do we do with it? Do we purchase more goods? Do we invest in more people? The common response is more goods. Let's buy more medicines. Let's build new centers. Let's buy new machines. Is that going to help us achieve universal health coverage? The answer is obvious. As we heard so well from Beverley, the principle is progressive realization or universalism. The idea that the most important investments to make towards universal health coverage is to focus on equity, to focus on population coverage. That is in fact what will make a difference. We can show some examples of how we've been able to help governments through this process by working with them to set priorities. Our colleagues at IARC and IAEA have worked with us to now develop a tool to help governments make those types of decisions. Just to give a simple example, if we work with a government and say, here's a basic package of services, they come back and say, okay, we have $2, we have $1 more per capita to spend. If they decide to spend it, they can entirely cover all women for trastuzumab. It'll improve their population outcomes 0.5%, and the cost will be insurmountable for most governments. The answer is not to say, yes, let's avoid all medicines, but it is to make practical and appropriate trade-offs focused on value for money. And second, let's remember what are the most important investments to make. Again, when we look at, and this is analysis that we did as part of WHO report on cancer, when we ask governments, these are the investments to make, most will come back and think that the medicines are going to be the ones that are driving costs. But if we look at what is the primary investment to make to increase coverage, it's not medicines. Medicines is 22%, but it's in fact people. So people are the biggest contribution that we need to focus on if we're going to achieve universal health coverage. Investing in the workforce, investing in communities, investing in primary care. The problem is this, the starting point. We've looked at every occupation across the cancer continuum, and the case is always the same. If we compare low and high income countries, the ratio of one provider per 100 or 1,000 patients is profoundly different. If we work in high income countries, as Sumit said, I'm a surgeon, I have a patient panel of, depending on the time and the types of procedure, a couple hundred per year. Let's compare that with what surgeons have to encounter in low and middle income countries or medical oncologists. So how do we invest in the workforce? How do we optimize the workforce to improve coverage? This is a journey we must take together. And then finally, to remember that if we put the people affected by the disease at the center of our work, that will always be the answer. Here's a photo of a dear friend that I'd met on the streets of Chicago, just outside ASCO. He passed away from liver cancer about a year after taking this photo. He's not asking for the most important therapies. He's asking for us to pay attention to his needs, to care for him. And this is what universal health coverage is about. It's not just about financing. It's about service coverage. It's about service availability and models of care that put people at the center of that care. Yes, innovation is going to drive us forward, but let's not forget why we're doing it. As Sumit said, we have multiple platforms within WHO to drive the progress. One, or the legislation that has been passed in countries. We're very pleased that Paulyn will share the brilliant work that was done under her leadership in the Philippines. There are other countries that we've been able to help now develop new legislation to support cancer as part of universal health coverage to help countries also build their workforce. As we heard from Beverley, she's right. We don't want to talk about it all the time, but let us also see COVID as an opportunity. The one point here, just to reiterate what Beverley said, when we look at when did most governments achieve universal health coverage, the turning point was in fact World War II. Times of destruction, difficult times for population, we revolve around health, we relate to each other through well-being. So now is the time to really build that narrative that UHC is the next step forward. We've learned a lot through the pandemic, the learning is not over, and this is the opportunity for us to craft a new way for health and for cancer to be part of that development agenda. Last slide, what do? UHC. If we ask each other, do you know what services are included in your benefit package? That should be a starting point when we go to governments. Do they know what cancer services are included and why? What technical and allocative efficiencies can we achieve? What drives financial hardship? If we don't know that, it will make it more difficult to advocate for the right things. Number two, invest in people. Let us make sure that while it is important to buy technologies, if we're not supporting the workforce, it is only going to become more difficult. I know many of you are providers. This has been a devastating 2 years, we understand. Many of you have put in extra hours in order to care for people in the community. You've put yourself at risk. Many people are beginning to experience burnout. If we don't invest in people, then our health systems will be at risk for the foreseeable future. Finally, let's come together. UHC is about a communal agenda. Yes, it's about cancer. It's about other agendas that can help drive us forward. Let's come together in a meaningful way to drive that step forward. Thank you.
Thank you very much, Andre. What an incredible talk. I think the marker of any good session is how excited you progressively get as the session goes on and how motivated, and I can feel both my excitement and motivation rising as through both of these talks. So our next speaker I'm very excited about as well, Dr. Paulyn Rosell-Ubial is joining us from the Philippines, where I believe it is 12:30 in the middle of the night there. So we are extremely grateful. Dr. Ubial has had an amazing, extensive career already, starting as a volunteer health worker and then progressively rising through the ranks to actually become now former health secretary of the Philippines. She has been a tireless advocate for cancer control, including such important issues as tobacco control, and was instrumental in the expansion of UHC, and so provides a real practical perspective to the topic today. So I won't say any more, and we'll pass the stage to Dr. Ubial.
Thank you, Sumit, and to the Canadian Oncology Workshop, and of course, the other speakers, Beverley and Andre. I'd like to thank all the organizers for this workshop, and I'm very honored and pleased to be with you this morning here in the Philippines. And may I ask Laura to share my slides? I will be talking about the practical issues that we have here in the Philippines in addressing universal health coverage and the cancer control program improvements in the past 2 years. So next slide. My talk will be on the burden of cancer here in the Philippines, a historical perspective of how we were able to pass a comprehensive cancer control law. And right after we passed that law, we passed the Universal Healthcare Law, and then the service providers for the cancer control program, as mentioned by Andre. The workforce is a very important component in providing universal health care. And program initiatives and accomplishments for the past 2 years since we passed the law, and the status of our initiatives for Medicines Access Program. Next slide. So here we are, the burden of cancer in the Philippines. I think we have an incidence of 153,000 new cases per year and a mortality of 92,000 deaths per year due to cancer. Our population is currently rounded off at 110 million people. So breast cancer is number one, followed by lung cancer, colon cancer, liver cancer, and so on. Next slide. So with that, we actually passed the National Integrated Cancer Control Act in February 14, 2019, after, I guess, 3 long years of advocating for its passage under the Duterte administration. So it was a landmark legislation, and of course, in the picture are the cancer control champions of the Philippines. Next slide. And it is an integrated approach. We had to rally all the key stakeholders, including local government units, the cancer control warriors, the doctors, the oncologists, as well as the patients. Next slide. And this is quite a busy slide, but actually this is the framework of how we intend to meet the demands and the needs for access to cancer care. And we identified who are the key stakeholders, how do we get there, and why are we doing this? What are the priorities and what are the cost-effective modalities in terms of providing cancer care access to our patients? Next slide. So in that last slide, I think I forgot to mention, it's really a whole of government and a whole of society approach. No one is left behind. So what happened with our cancer control program and the law was that it provided increased investment in cancer control, and therefore a widening of service access points in the country. So we started with around 10 cancer centers at the start of the Duterte administration. Now we have 27. And these centers are providing free cancer medicines for the 8 priority cancers in the country. Next slide. So with this, we started from 2012 up to 2017, 5 years, where we benefited 9,510 or around 2,000 patients per year. Now we are implementing it from January to March only, and we were able to provide access to 3,841. So it's the biggest access point for cancer patients, just because we framed the cancer control program under the framework of universal health care, leaving no one behind and identifying our priority strategies and priority population. Next slide. And the current cancer control program initiatives includes a lot of action at the various levels. There's the national policy and standards development. Then down the line, training, technical working group meetings, and creating the clinical practice guidelines so that we can actually put the cancer control benefits into the National Health Insurance Program. And ongoing is the conduct of an annual observance of Cancer Awareness Month, raising awareness and also raising the Filipino health literacy, as well as providing a framework for patient navigation in the cancer control program. Next slide. And other initiatives also include drafting of the standards and policies, creating the program, Cancer Center Management Office at the Department of Health, and the construction of the Philippine Cancer Center, which is now underway at the University of the Philippines Philippine General Hospital. So that's our national cancer center, and also the seat of the cancer research in the country. And we have special projects with the World Health Organization, as mentioned by Andre, to actually expand in a progressive universalism manner, as explained by Beverley earlier. Next slide. So this is the roadmap or strategic map for the Cancer Control Center, from which started in 2019 and well into 2025, and the achievement of the Sustainable Development Goals in year 2030. So it's starting with a coordinating office with a point person and training of human resources. And phase 2 is establishing the research facility as well as the cancer registry. And then phase 3 is actually putting the physical specialty hospitals and access points across the country. Next slide. So as you can see, the line graph on the right side of the presentation is the dramatic increase in resources available for the cancer control program as soon as we got everyone on board and the law was passed. I think that's the main issue in the Philippines, that we need to have a law to improve access as well as program development in the country. So the Universal Healthcare Law and the Cancer Control Law was passed both in February 2019. It was waylaid by the pandemic, but we hope that it will be on track towards the final realization of universal healthcare by 2025. Okay, next slide. So the budget actually is about 8 times that of the budget when we started with the Duterte administration in 2016, when I was health secretary. So it has improved quite a lot in the past 2 years. Next slide. And as we can see from this slide, Cancer Medicines Access Program has actually expanded from 2 cancers, breast cancer and childhood cancer in 2016. It's now covering 8 cancer types, and currently from 10 access sites in 2016, it's now 27 access sites. So from about less than 4,000 patients in 2016, it's now being accessed by 25,253 patients. Next slide. I think this is my final slide. So I just want to give you a perspective that the budget that was approved by our Department of Budget and Management is to a tune of around 16 million US dollars from a budget of around 5 million US dollars in 2016. So it increased about eightfolds, and it's now catering to more than 26,200 patients for the Medicines Access Program. And Cancer Assistance Fund is actually to look at the other out-of-pocket expenditure of the patients, like diagnostic and screening, as well as palliative care, and to assist patients get access to this supportive treatment and diagnostic services, as well as palliative services. So we're looking at 38,000 patients being provided with a budget of 18.6 million US dollars. Used to be, there was zero amount for this type of services in the budget. So now it's helping 38,000 patients that used to get this pool of funds from out-of-pocket expenses. So there you have it, and we hope that we will see in the future how the increase in resources will actually benefit the strengthening of the entire health system in the Philippines. Thank you.
Thank you very much, Paulyn. That was incredible. It's actually mind-boggling to think of how much impact the initiation and expansion of this program. Incredibly inspirational. I'd like to welcome all of our speakers back to our panel now over time, which I think is absolutely fine given how amazing those talks were. Session is next. I received official permission from Laura, whose word is law, to go a little bit over if we have to. So that's great. Please feel free to put in questions, and I'll take moderator's prerogative and ask one question of each panelist, and then maybe one overall question as well. So maybe Andre can speak with you, or with you rather. The WHO, when governments have or expand UHC, is cancer usually something agenda or that they're talking about already, or is that usually a sell that the WHO or cancer advocates have had to make in your experience?
That's a great question, Sumit. A lot of this has to do with timing within a government's planning cycles, as we heard so well from Dr. Paulyn. What this process requires can require years. The question is, what is the outcome of interest? Because success in building that journey towards universal health coverage isn't defined just by an outcome like increasing the number of services in a package or increasing the complexity of those services or the number of people covered. Those are monumental occasions, or the legislation like what we heard from Dr. Paulyn. These are monumental moments. But those types of major health sector reforms don't come every year. So it is about timing it right, ensuring when the dialogue is happening, the cancer community is there. But that doesn't mean that in the interim years, we just stop and passively wait, because there are other mechanisms that we can focus on to reorient how services are structured. Perhaps it's through a different cancer policy or program. Perhaps it's an investment in a certain set of services, and by activating communities in different ways.
There's just a bit of feedback that Laura, I know it's not and
I wasn't hearing any feedback. I'm hearing a little bit of crackling from your microphone now, but let's try going back to Andre and Sumit. Maybe if you can just mute for the moment and see if that resolves it.
Please, if there's any problem with the audio on my side, I'm also happy to reload. But just to add that there is the preparing ourselves for when we see a major health sector reform or policy formulation episode. whether it's the cycle of a cancer control plan, again, broader national health planning that often happens every 5 to 7 years. Those are the primary entry points for a major reform that we can insert ourselves in the cancer agenda. In the interim, there are still opportunities for us to leverage a smaller dialogue. As an example, we were in a middle income country working to decide there were some additional resources available through the Ministry of Finance that were going to be directed to cancer. We were able to use an investment case to justify that. We weren't asking for a large portfolio. It was almost a special program. And we had to decide, can we, in a 1-year period, develop a program that reflects the needs of that country? And in that regard, we were able to develop an interim solution and wait for that broader health sector reform where we see the opportunity to leverage our work into universal health coverage. It seems, Laura, we lost Sumit, but maybe just to hear from Dr. Paulyn and Dr. Beverley, it would be wonderful to hear their thoughts on how do you approach the timing of that dialogue, and what can we as advocates, as leaders in the community do to continue the drumbeat? So maybe they can also offer some insights. And it's there's some important questions coming also in through the chat. So maybe Dr. Paulyn can continue, and then.
Thank you, Dr. Andre. I think in the Philippines, what matters most is that the dialogue or the conversation around cancer control program and expanding the program did not stop. Like there was several stumbling blocks, and there was several, shall we say, challenges in terms of funding and access. Why will we prioritize cancer when we have not actually attained immunization coverage at this point in time? So there was a lot of challenges in terms of getting this, but I think what's important for countries to realize is that they don't stop advocating and continuing the dialogue until, I think the most important part in the legislation is that each member of the legislature in Congress and in Senate, they have a personal stake in the cancer control program because they have a family member, a friend who has died of cancer, and it became a personal crusade for many of them.
Thank you very much. I apologize. That was the feedback was totally on my end, so I just had to leave and rejoin. Can I ask then, building on that, Beverley, you talked about the importance of making sure coverage for all and equity in these programs within the cancer realm of UHC. Are there policy or financing levers beyond just coverage for all that can ensure equity in cancer coverage when it comes to expansion of UHC to include cancer services?
Yeah, so thank you. We've lost you a little bit again, Sumit. It might just be on my end. So we're having some problems with this platform. I think in part it's also it requires looking at the investment that's required as an investment. And I think cancer has been seen as very costly. I think Andre did a very good job of showing that the bulk of that expenditure comes from paying for human resources and quite expensive specialist-led models. And so dispelling that will also help to free up some of the resources available and use them differently. I think innovation and technology have a role to play in changing that. But I think taking sort of a step out and understanding that the realm of possibility, the scope of benefit exceeds far beyond the health system, and that it cannot be seen as a cost. It can't purely be seen as a cost, but has to be seen as an investment in healthy longevity, in the health of populations, in human capital development, and all of these other important metrics, as well as well-being in its own right. And so I think changing that narrative helps to understand the investment case. And so when we get to how we actually fund it in a way that allows us to ensure that we're addressing equity, one of the pieces, I think, which links back to the plenary yesterday, is starting from a place where we understand the needs of the population. And so a lot of the global push and prioritization has happened using global data, as well as data from a selection of countries. And I think that was very important to build momentum. We're now at a place where there has been some lag in individual countries having the local evidence, and it's not necessarily an issue of capacity. I think it's the evidence base to support local planning and local priority setting. And without that, it's hard to make quite nuanced prioritization decisions around where and how and who to focus action. And so we've time to move from sort of a generic suite of interventions to thinking about the ways in which we understand the needs of a population, we invest to support, to close those gaps within populations. And that relies on information, it relies on data, it relies on research, and an investment in what I was floating and maybe sort of went by quite quickly, this sort of innate information enabled systems. And there has been a real underinvestment within, I think, high income countries and low income and middle income countries alike, but we see it play out differently in low and middle income countries, where unless we have a good understanding of the population needs, it's hard to identify the inequities, measure them, and then appropriately target intervention to address them. So I think that also I would link back into how we make the case for the investment case, the value proposition of ensuring that we have the data, the information, the research to support local and locally led decision making and priority setting, so that it's not entirely reliant on model data or very old data that doesn't fully capture the current population needs. I'll stop there just in the interest of time.
No, that's great, Beverley. I think many people in this audience would cheer anytime someone talks about the importance of building data structures into any of these initiatives. There's a couple of questions in the chat that I'm actually going to combine. So Mary had a question specifically for Andre, but I think everyone can speak to it on, how the WHO or other bodies are working on increasing the overall investment in healthcare in cancer in low middle income countries. And maybe I'll link that to a question that Anna put, which is, Beverley's last slide about the silver linings in COVID. What can we learn from how we have or haven't shared knowledge or funding or financing during the COVID crisis and apply it to increasing funds towards something like global cancer control? I don't know if Andre, you want to start us off on that.
Sumit, of course, great questions. And Mary, it's so nice to read and to appreciate the legacy that you've created in advancing this movement for increased financing in cancer. So this is a very real challenge. This is not unique to this moment in time for cancer or for the broader health financing agenda. We know that there have been countless opportunities and times for governments to commit to spending 1% of their GDP on health. When we look at the Abuja Declaration in the African region as an example, many of the governments perhaps increased their expenditure briefly, but then it stagnated again. The foundational problem that we have really is that health remains a lower priority in democracies and for general populations. People don't act on behalf of health as a priority. And when voters don't request schemes of universal health coverage or increased financial protection, we don't see motion. So what we are also trying to do in the community is to create a stronger story. I think Paulyn said it exactly right. When an advocate or a politician has a personal link to cancer, that changes. And what we often are now focused on is, yes, cancer is bad, it's scary, but we don't tell the full story. So we're spending a bit more time now at WHO meeting with survivors, meeting with advocates, and trying to understand what are the dimensions of your experience that we need to hear, because there investment cases now are a dime a dozen. We have plenty ourselves in cancer. That isn't enough to take us to the next level. It's more about how do we craft the narrative, as Beverley rightly pointed out. What's the broader social and economic value? What is the disruption of a cancer diagnosis on the marriage? What is it disruptive on educational opportunities or reintegration to the workplace? If we can start creating that better dialogue, that this is not just a disease that stops at the hospital doors, that it's a disease that infiltrates into our communities, into our ethos, then we may have better traction. Another thing, just briefly, and I don't want to take too much time because it's so nice to hear from others, is to be honest about how we are currently spending money and current data. So working with partners, again, with IARC and IEA, we've developed a tool now that we've used specifically in 3 countries where we identify what priority interventions do they currently finance? What money are they spending? What medicines are they purchasing? How much money is spent on it? What hospitals do they have? Where are they organized? And if we really do that analysis, one of the entry points that we're trying to develop now is, look, you can save money if you in fact invest more wisely. We have a country that we did this for, and by shifting away from targeted therapies that were inappropriately prescribed, we were able to actually increase population coverage in that country and increase the number of medicines on their essential medicines list. So it is about the overarching envelope. That for sure is a priority. But for us, it's also within that envelope, what can we do to rearrange it, to restructure and improve efficiency? And governments seem to be receptive for that. Once we show success, then we can say, now let's add to that envelope, but let's show you up front, you don't need to add more to do more.
I think I would just to build on to that point that you're making, I think in looking at the, what we call the investment case or the costing estimates, I think we have to be mindful of not, embedding inequality within that estimation. So a lot of the Best Buy work, a lot of the costing of packages and of services have ignored whether it was, I don't think it was purposeful, but it have ignored the family impact and the reliance on unpaid care that is so crucial to sit along health systems and provides, fills gaps within these systems. And in addition to that, there's, an undervaluing of women's contributions to the health work within these systems. And so as we think about building out, as we think about, the road to progressive universalism, as well as taking into, part of taking into account some of those broader impacts is to recognize and appropriately value that cost, which has been a subsidy within health systems. And I think that helps to change the value proposition because that frees up individuals' time to then become productive members of society, to then invest in their own health in a way that isn't possible if we continue to rely on it explicitly within the planning for cancer. So I would just add that to the point you were making, and I think it relates as well to the bulk of human resources that are required to deliver cancer services.
Thanks, Beverley.
On that investment for cancer control and the universal health coverage, I think the best way that I can think of convincing our political leaders to invest in health is actually to identify where you are now and how far do you need to go in terms of an ideal health system that you want to realize, and how much will you need to invest in order to get there. I think politicians need to see the figures. If we invest this small, this is how much we get. If we invest this big, this is how much we get. And I think what's really important is that the politicians realize that there's value in investing in health for them. That it's not just a personal or individual issue, but it's a societal and a whole of government issue that if you invest in health, everything, the economy, the government, and everyone will have a better, it turns out to be better for all of us.
Thank you very much, Pauline. That seems like a wonderful sentiment and idea to wrap up on. I want to thank Andre, Pauline, and Beverley for really fantastic talks and fantastic comments. Like I said, I leave this session, I think, more knowledgeable and more enthusiastic and motivated than we started, which I think, again, is the mark of a great session. So thank you again. Special thanks to Pauline for sticking out past 1 a.m. in the morning. And I'd also like to thank the co-organizers of this session, Anna Darris, and a massive thanks to Laura Carson, who really was the blood, sweat, and tears behind putting this together. And I will pass it back to Scott.